All right, let's go over the respiratory system, another respiratory emergency would be epiglottitis and croup. We kind of tie these two together because they are upper airway issues that occur in this supraglottic area, so above the glottic opening. And in most times, these were considered your pediatric type conditions. It was more of a childhood illness that would occur. And we know that the agents for these was a virus, HIV, and then in this one, we know that this is parainfluenza that causes this inflammation. So let's talk about this upper airway again. The upper airway is above this glottic opening. The lower airway would be all of that pulmonary circuit where we have the gas exchange as it passes through the trachea and down. And then we have the alveolar circuit where gas would be exchanged. We're talking about a blockage in that gas to get to that exchanging unit. This traffic jam, if you will, or blockage is higher up in that upper airway. And our treatments now are going to be entirely different from treating something in the lower airway where we would try maybe loosen up the smooth muscles around the bronchioles or rid the fluid out of the lungs or try to give some fluid to loosen up the thickened mucus or antibodies. Here we have, it's in a supraglottic area. Epiglottitis, again, childhood infection. We usually immunize these our kids now so that there's less likelihood of having this. The problem is that the elderly adults and our late adult population is now being seen to pick this illness up because they have lost that immunity over time. And because the community, we live in multi-family homes where we have different generations sharing it, if the children haven't been immunized, then they can pass that on to our weakened or immune compromised individuals on the farther end of the lifespan spectrum. So again, it's an illness that affects, usually it's this flap of tissue that sits just above the glottic opening. Its particular function is to cover the windpipe, that glottic opening, when we drink something, swallow, or eat something, so that we don't aspirate that contents into the lungs. In this particular case, when this is inflamed as a result of that infection, this flap of tissue becomes so inflamed that it becomes too heavy to lift up and down, and what happens, it just sits on top of the windpipe. And if you will, if you were to just put a cover over your mouth or to cover over that windpipe, you can't get gas in because it's going to suck against that epiglottis, and now the person can't inhale, and they're going to be suffocating or asphyxiating because of this anatomical issue. Because it's an inflammational process, they're going to have other constitutional symptoms. They're going to have this fever. They're going to have maybe an upper airway issue where it slowly started, and then they're going to have the difficulty breathing, the high fever, drooling, sore throat, muffled voice, a hot potato voice. These are some of them are classical symptoms. So they're tripoding or they're drooling, they're saying that their throat is sore, they can't swallow. And every time that they lean backwards or lay flat, because of the inflammation to the epiglottis, it kind of covers over their windpipe and they can't breathe. Any irritation to the soft tissue, such as exploration by using a laryngoscope or a tongue blade to look into the oropharynx to see down in the hypopharynx or down in that area, could cause any type of aggravation. And if it's inflamed already, the more you aggravate this tissue, the more inflamed it becomes, and then it becomes a occluded airway. So the treatment for this is really, they're trying to figure out, well, the racemic epi, they thought maybe it would cause vasoconstriction, so it would decrease the swelling because blood flow to that tissue would be decreased, right? Vasoconstricting. Plus or minus, they also mentioned using something called decadron, prednisone, or decadron or prednisone. Remember that was your catabolic medication. It was to block the process from continuing on. So it was going to stop the inflammatory process. Again, another thing that's, it works, but it's slow to work. And we're talking about a life-threatening situation where you can't get oxygen and the person can basically asphyxiate because of this anatomical inflammation. So leading them forward is a good position so that the flap of the epiglottis remains forward and upright as it sits up. They want to stay in this position. It also helps clearing out the airway so that they can clear out all the secretions so that that's not causing an issue with the airway. If you are using a suction device, if they can tolerate doing it on their own, just have them kind of keep it in the corner of their mouth, like you would at the dentist's office, just so that they can help clear it out. Flow by oxygen may help, but really we want to watch to make sure that this doesn't get any worse in the course of transport. What we like to do is keep around what's called our cricothyrotomy kit, a new trach, a quick trach, or any type of surgical trach device, so that in case this becomes an occluded airway and the person is asphyxiated, we can quickly put a window into that opening, cricothyroid membrane, and take over ventilation. So on the x-ray of these patients, basically when they show the x-ray, they show this big floppy tissue right over that windpipe. And you might see this in a test or a textbook, but they call it a thumb sign because it looks like a big floppy tissue, like a thumb, that's just laying over that epiglottic opening, just above the trachea. Now move over to croup. Again, it's usually a childhood illness, early childhood, and these patients, they have this type of seal or a type of barking type cough. It usually is aggravated a little more at night. I don't know if the nocturnal or circadian rhythms cause it to be an issue, but we tend to see a lot more patients during the evening time, and then they come in with this barking type cough. In this case, it's caused some inflammation and swelling, if you will, in this back area. Of this hypopharynx area. So again, it's an upper airway issue where we can't get the air in, and it's narrowing this so that any air that's trying to come in is limited, and the gas exchange then would be limited, and the air going out is also limited. If you see on x-ray that it looks sort of like kind of like a steeple. And on top of the churches where it kind of pinnacles up because of this narrowing. Slightly different. You don't necessarily have the drooling or the tripoding, but they do have that raspy, stridorous sound maybe on inhalation. You would have that croupy type, still like bark and cough. You would have other symptoms that maybe as a low-grade fever, slight fatigue. Entirely two different cases. One's very life-threatening, the other one a little less. Usually of the pediatric age groups. Again, we take on and do our, look at our EKG if we need to, but pulse oximetry, skin color, lung sounds, and in this case, lung sounds in the lower respiratory tree here should be clear, or if you're hearing anything, it's transcended or transduced from the upper airway. And as you listen to the lung sounds bilaterally on the anterior and posterior surface, when we listen, try to go up and then listen directly over the windpipe area here, or the neck portion and the anterior portion here, to see if you can hear those sounds much louder here than you would down here. A lot of the treatment then is supportive. We can give oxygen if the SATs are low, and then try never to visualize or aggravate the epiglottitis patient.